Oh, thank you. Well, we are going to talk about language in the brain today. So first of all, I'd just like to acknowledge the Turrbal and Yagara people of Brisbane and acknowledge their leaders past, present and emerging. And also the lands of my university, QUT, those lands have always been places of teaching and learning. So I'm the Deputy Director of Herston Research Imaging Facility. So we're based on the Royal Brisbane and Women's Hospital campus, which is really quite big. So big they've given it another name and called it the Herston Precinct. So while we're not in the main hospital itself, we're still very close by. And we are designed to do that clinical translational imaging. So we're set up like an imaging department, but we're a little bit removed so that we can spend longer and do some more detailed imaging. So this is the kit that we have. We have a high-end 3T MRI like Mātai does. We have a PET MR. It's one of only 4 in Australia. We have a PET CT as well. So PET stands for positron emission tomography, which is where you inject the radionuclide dye. We also have a Vectra system that's really just for surface imaging. So it's a fancy set of 92 digital SLR cameras, and it basically creates that 3D digital avatar with really high resolution so that you can zoom in. We also have bedside imaging with a little ultrasound system, and we have a really baby MRI system. So this system here is 0.064 Tesla as opposed to 3 Tesla for our big beast. So it's only got a head coil in it, although I'm told you can do hands and feet. It's portable, so you can literally roll it to the bedside of the patient. The patient doesn't have to come to the scan. And it's with us so that we can, basically, we're getting paired images between this little guy and this guy to try and artificially increase the image quality that we get off the little guy. So the long-term goal is to send it out to remote and rural Queensland to see if we can help with triage and even follow-up care so people don't have to travel as much. And that's sponsored by the National Imaging Facility, and Dr. Gary Cohen's going to speak to you tomorrow about that. So here in the next 1 minute, we're going to talk about, you're all going to become experts of what the language looks like in the brain. So in listening to me, you're using your auditory cortex, which is in purple there, and you might be watching my gestures or reading my mouth, and you're using your visual cortex there in blue just to take the information in. Then if to understand what I'm saying, you're using this area in green, which is what we call the semantic system. But basically it contains all the facts. So if I showed you a picture of a cat, you know that a cat had whiskers and a tail, was a mammal, and you'd also have all the associations. So it's raining cats and dogs would be in there as well. Oops. If you're processing single words, you're using that little orange area. If you're doing sentences, you're using the green areas. There's really hard-working integration hubs in those yellow areas that are trying to pull all the information together. Then we come to the other side of the system, which is you responding. So you might want to say the word cat. You would need to get those sounds together, and that's in the red system. We call it phonology. And then you actually have to say it or write it. And then you're using your premotor, your motor system, your somatomotor system, and your cerebellum as well. So as you can see, it's a really extensive network. If you're right-handed, it's going to be on the left hemisphere. So it's our left hemisphere shown there. If you're left-handed, there's a chance that the whole thing could be flipped, and it'll be on your right hemisphere. And if you're right-handed and your left hemisphere dominant, there still will be parts of the right hemisphere that are involved, but most of it will be sitting on your left. All of that areas are basically supported by this white matter network, which carries the information around the different systems. And if you have a stroke, like this unfortunate person here, depending upon where the stroke is and the extent of it, will depend upon what language deficit you might be suffering from. So I'm going to give you a really quick tour of our research, which today is going to cover stroke, brain tumour and epilepsy fields. So you're probably really familiar with all these types of diseases. Stroke is fairly cataclysmic. You've got a blood-brain blockage, so your tissue is start to starve. The quickest I've ever seen An image is someone who got to the hospital in 30 minutes and there was already damage occurring. So if you or your loved ones have a stroke, get them to the hospital as quickly as possible. Brain tumour, obviously there's different grades, but it's a slower process. And usually by the time you have symptoms, there's already a tumour there. It might be pushing everything out of the way, or it might be infiltrating into different areas depending on the tumour type. So there's a little bit more time and space in both of these conditions for what is known as plasticity, which has already been talked about today. So epilepsy is that electrical disruption that happens randomly later on, but usually by the time someone's coming to surgery, they're much younger. They could be anywhere between 20 and 50, whereas the average age for 50 plus, obviously age, and time for surgery, there's really a pediatric cohort for surgery and also an adult surgery, which is around the 50s. So all of these brains are of different ages by the time the pathology really kicks in. So to talk about stroke first, we have a big study that is looking at trying to predict recovery and the best treatment after stroke. If you have a stroke, you're about 30% likely to have some kind of language deficit. And at the moment, there's really no good predictors about, how well you're going to recover. People with a lesion in the same place can have very different trajectories. So we were asking about whether we could find some predictors with MRI. So the study was quite big. We were looking at lesions, we're looking at different kind of network connections, resting state like Herston just mentioned, structural as well, looking at brain function when they were doing different language tasks, also pulling in different psychosocial factors. But the one I'm going to run you through today is the brain reserve. So our theory is, this is a 50-year-old brain. I'm not saying it's mine, mine's worse than that. But one thing to note is that, the ventricles are maybe getting a little bit larger, but you're starting to get these little white matter diseases just around the ventricular horn. And this is quite normal. This is a normal, healthy brain. They might have some tip of the tongue, word finding difficulties, but otherwise perfectly normal. That's the same brain, let's say, at 50, but this person either is a smoker, has high cholesterol, high blood pressure, and you can see their ventricles are much larger, and the extent of white matter damage around the ventricle horns is much more extensive, but also we're seeing it along the major white matter tract, so you get these little white matter damage there as well. So our theory is if you have a stroke with a brain like this, that you're going to recover less well than if you have a healthy brain to start off with. So that's someone who's had a stroke but also has some white matter damage that would have had premorbidly before the stroke. You can see that there's a lot of white matter damage sitting around the lesion area. This is quite early on in a stroke, so there's a lot going on. There's some edema and some other stuff happening. So we just looked at the right hemisphere. It's usually in the older brain, it's quite bilateral, the damage, so we used two different scales on this. A clinical scale, which is just a score from 0 to 6, and also looked at whether the volume and where it was placed mattered to how well people were doing. So we used two different parts of language to test that. We used both our production and our comprehension skills. So to test our productions, we did just naming pictures. That's a very common clinical test. They just give you a battery of up to 400 pictures. You name it as quickly as possible. The other very common test is verbal fluency, so give me as many words as you can think of, starting with the letter F. And the other one was to show them a very complicated line drawing and get them to explain what was happening into the picture. So 3 different levels of production and also 3 different levels of comprehension, single word, sentence, and paragraph. What we found was if you had a really severe white matter clinical score, you basically had poorer language comprehension 6 months post-stroke. And if you had a larger white matter lesion load in the corpus callosum minor, that's a white matter tract that's connecting your hemispheres, you also were likely to have poorer comprehension. So one thing to note is there's no correlation with production. So the language modality really makes a difference, but your brain health as you get older does make a difference to how well you recover in some forms. So tumours. So this is an adult tumour that has been resected. You can see the black little resecting area, and unfortunately for this person, there's also a little bit of reoccurrence that's growing around the side. Tumour is very little studied for language. So basically you have the resection and are sent on your way, and there's very little follow-up. So there's not much in the literature. We wanted to ask whether it was being tested correctly, because most of the language tests are designed around stroke, since that's the largest group that has been studied. And we also asked the neuroimaging question, like, can we use these predictors to try and improve their long-term quality of life? These are the behavioural results you can see. So we did 3 different tests. We did the current clinical test, which is called the Western Aphasia Battery, or WAB to its friends. And we did a more detailed language test, which is called the CAT, or Comprehensive Aphasia Test. And we also did a subjective test. So this is just ask people how they felt their language went. So of interest to me was that there was about 18% which wasn't covered by an objective test. But when we asked people about these, it was something that was never going to be covered in an objective test. It was when they were tired or overwhelmed or in a loud, noisy environment or something like that, not in a little controlled test environment. The other very interesting thing to me is that basically the WAB on its own didn't show any deficits that weren't already covered by the CAT and the subjective. And of the CAT tests, so there's quite a few tests, the biggest subtest that showed the largest number of deficits in our cohorts was confrontational naming verbs. So that's important, because if you have limited resources, you're only going to get that confrontational naming of nouns, of concrete pictures, whereas if they could switch it to a verb naming, they'd already show much larger deficits than they do currently. So our brain indicators, we wanted to look at the lesions in the brain, so that's our little resected part. But there's also, as I showed before, all this extra stuff that's happening around the outside of the actual resection. Sometimes it's edema, sometimes it's radiation therapy damage, sometimes it's just the tumour has infiltrated into that white matter and that has become damaged long term. So we wanted to look at both of those and also the difference. So basically the subtraction is this blue area here whether it's just the residual damage that plays the important role. So what we found was, if you have some damage in your anterior temporal lobe here, in your resection plus map, so that's resection plus extra damage, then you're going to more likely to have verb naming deficits. And if you have an area in your inferior parietal lobe that has been damaged in your resection plus or just the residual, then you're more likely to have the spoken sentence comprehension deficits. So moving on to epilepsy. So epilepsy can be global, that you just have this global disruption, affects many lobes. There is no surgical option for that because there's too much to cut away. Focal epilepsy is where they do the resection surgery, and obviously the foci can be in any of the lobes, and your symptoms will change depending upon which lobe you're in. But the main 3 that will cause language deficits are frontal, temporal, and some of the parietal, if it's got a focal that's at the back here. So this was a PhD study that's Aoife Reardon, our PhD student, conducted. So she did it in 2 parts. One was to look at that, comprehensive testing. Based on our tumour results, we didn't think they were potentially testing epilepsy in the right way. And also to optimise the functional brain mapping. So what they do in Australia in some hospitals, not all, is that they'll do some very basic, maybe 2 or 3 tasks with the patients. It'll be delivered very simply. There's no response. There's no way of knowing if they're doing it right. And we thought, at being nerds and scientists, maybe we can optimise that and do it a little better. So the behavioural results, the 2 most common tests with epilepsy are the Boston naming test, that's that confrontational naming, and there's also verb fluency. That's the only 2 tests they really get if they get that. you can see that all the Boston naming tests were more than covered in between the CAT and the patient report, and there was basically no deficits in verbal fluency. So if that's the only test the epilepsy people are getting, they're saying, oh yeah, you're fine, just go home. Of this, again, the verb naming was the highest, so about 73% of the cohort showed some deficit in the verb naming, and they're the other top-ranking subtests there. So for our epilepsy task validation, we started with control, so I'm going to show you the control results right now. We have just finished collecting our epilepsy cohorts, which have frontal and temporal lobe, but we haven't analysed them yet. So we chose these two because they're the two most common already done in the clinic. Sentence completion, lions have very sharp teeth, so they're usually quite simple sentences to complete. There may be one or two words that you could choose from to finish it off. And in functional imaging, you have to have something at a baseline state to take away all the activity you're not interested in. So to take away our visual processing, we just gave them a random string of letters with no meaning or content. The other one is our verb fluency, basically. Give me all the words you can think of starting with A. So in most cases, there's no response. We ask them to press a button for every word they could think of, because if I said that to you, some people have got 3 words in their head, some people have 12. And you know, the people with 3 words, they get a few seconds to do this, and they're already thinking about their laundry list, what they've got to do on the weekend, they have to pick their kids up. So that activity is not actually going to be reflected into the task. Then we chose 2 different semantic tasks because we'd already had the results from the verb importance from our tumour study. We did both a noun, so they would get this target, and 2 words that they had to select from with left or right button press, the one that matched closest to the target, and that was either a concrete noun or a verb. And the baseline was just a numerical, which one's closest to the target number. Then we had 2 different adaptive tasks. So adaptive tasks will get easier or more difficult depending on how the performance is. So there's a feedback loop that is built into the task. And if you're a highly educated person who's got epilepsy, who's performing really well, this will get more and more difficult so that you're kept engaged. So that's the big problem with a lot of the tasks, is that if you're not engaged, then the activity you see is that laundry list that I mentioned before, instead of actually the semantic or the phonology that we're interested in. So we had 2 very similar. One for semantic, you just had to say whether these 2 words were matching, were the same, or whether the baseline was the same. And I've just got a bell, so I'm going to speed up. So the other one was all pseudo words, and you basically had to say them in your head to see whether they rhyme together and then press a button. Our last test, I'm so close, is a really novel writing test. So that really rarely gets tested in the scanner. People think it's too difficult. And we ask them to write an autobiographical paragraph. I'm going to flick very quickly through these. Basically, we found all of the tasks in the controls were the same level of reliability. For the very simple ones that we got feedback from our controls to say they were bored during the task and they were basically forgot what they were supposed to be doing. This is the only standout. The one we were hoping for, our verb semantic decision, is very low reliability. That means when we got them back in 3 months, they were not using the same network they were using to start with. The other really exciting thing is that our novel writing task goes all the way down to the anterior temporal lobe. That's important because that's an approach that they often use for resection. So we need to show to the clinician whether it's being used or not. And basically all the participants will be able to complete the task. So we actually gave them something to write on, but they couldn't see it. It was on their leg, but they had no problem doing it. And we were worried because of the motion of the hand that maybe their head would bop along while they were writing, but the motion artefacts were all within the same limits of the other tasks. I'd just like to thank everybody. It obviously takes a village to do this type of research. So I've worked with some very talented clinicians and researchers over the years. And thank you again for your attention.